Thank you for joining us today for our final webinar in our Back to School campaign called Oral Food Challenges, What They Are, and How You Can Gain Insight into Your Food Allergy. I am Jennifer Gertz, Executive Director of Food Allergy Canada. Before we get started, I wanted to note a few items. This session is for informational purposes only and will not provide specific medical advice, recommendations, diagnosis, or treatment. Please talk to your doctor about any concerns or questions you may have regarding your own health or the health of your child. All participants are muted so we can keep the audio clear for the webinar. Thank you to everyone who submitted questions on registration. There are some common questions that we'll tackle in today's session. If you have additional questions during the session, please submit them in the chat box throughout this webinar, and we'll try to get to as many of them as we can. This webinar will be recorded and shared on foodallergycanada.ca afterwards. Now, some background on today's session and format. It's likely that most of our listening audience today has had an official diagnosis of a food allergy or supports someone with a diagnosis. It may have been a recent diagnosis, or it may have been 20 years ago. That diagnosis likely included a discussion of personal history with the food and a symptom of the reactions, a skin prick test, and maybe an IgE blood test. And if confirmed allergic, then you were probably told to strictly avoid the food that triggered it. It's not often that an oral food challenge or an OFC is considered in that mix, and in some ways it's hard to imagine why anyone would want to consider such a procedure, given that it involves eating the food you've been told to avoid. Yet we hear that OFCs are becoming more common than they were 20 years ago. Today's session will be all about oral food challenges, or OFCs as we call it, and having our expert help us understand the most recent learnings about them, what they are, and how they might be considered useful. The session covers 4 areas: setting the context of what an OFC is and when it might be considered useful, what's involved in an OFC, the value of an OFC, balancing the risk and benefits, and then we'll talk a little bit and we'll end off talking about access. Our expert will walk us through a few slides, and then we're going to break a couple of times for questions that you submitted that are relevant to the specific area that has just been covered. As we like to do with all of our webinars, we like to begin with a poll just to get a pulse on the level of understanding and experience with the topic that we're talking about, in this case, oral food challenges. So if we could have our listening audience answer the following poll questions. Are you familiar with an oral food challenge? Yes, no, unsure. A good portion of our audience are familiar with oral food challenges. There's some in the no and a quarter in the unsures. The second question, have you or your child undergone an oral food challenge? And in this case, we're looking just for yes or no. So we've got 64% saying no and a third of the audience yes. Okay, that's really helpful to understand and helpful for our expert to know who's in our audience today. So I would at this time like to introduce our expert, Dr. Edmond Chan. Dr. Chan is a pediatric allergist at BC Children's Hospital Allergy Clinic, University of British Columbia clinical professor, and also at BC Children's Hospital, he is the clinical investigator of the Research Institute and head of the UBC Division of Allergy and Immunology, where he leads a food allergy research program. He has over 160 peer-reviewed publications, primarily on allergy, and is a co-author of several national and international guidelines on food allergy and eosinophilic esophagitis. Dr. Chan is the Secretary-Treasurer of the Canadian Society of Allergy and Clinical Immunology, on the executive of the Canadian Pediatric Society's Allergy section, and on Food Allergy Canada's Health and Care Advisory Board and the Steering Committee for Canada's National Food Allergy Action Plan. We're absolutely delighted to have Dr. Chan and someone with his knowledge and esteem be able to join us today and walk us through the first part of this session, setting the context, introducing us to oral food challenges and how they're conducted. Dr. Chan, welcome. I'll turn it over to you.
Okay, thank you very much, Jennifer, for your kind introduction. And thank you to Food Allergy Canada for inviting me to speak for this webinar. So we're going to start on this topic with just looking over the outline. And what we're going to go through during this session is to understand what food allergy is, and look at food allergy challenges, oral food challenges, and who may be candidates for one. Describe what's involved in an oral challenge, and describe the potential value of an oral challenge and end off with comments about access to oral challenges in Canada. Next slide, please. So what I like to start with quite often is, what does food allergy truly mean? And if we take a few steps back, we don't get to the term food allergy until we describe what an adverse reaction to a food is, which is a very general concept of any abnormal reaction to a food, which can be subdivided into toxic versus non-toxic responses. And so toxic are your typical food poisoning type of situations, and non-toxic would be then when you start getting into food allergy versus food intolerance. And sometimes it's easy to confuse the two terms, but an easy way to distinguish them is that food allergy has something to do with the immune system, whereas a food intolerance is non-immune mediated. And so an example of that would be lactose intolerance. Next slide, please. So here we have specific examples that delve further into these terms. So food allergy can involve IgE-mediated reactions, which are the subject of today's talk, potentially anaphylactic food allergy, oral allergy syndrome. They all involve specific IgE antibodies that your immune system makes against certain foods. Then you have, as Jennifer mentioned, the condition eosinophilic esophagitis, which involves IgE antibody, but also involves other immune cells and mediators with delayed responses. And then you have a condition such as FPIES, or food protein-induced enterocolitis, which is a non-IgE mediated food allergy. So it still involves the immune system, but there's other factors such as T cells, which result in delayed immune responses. So with FPIES, what we see clinically is delayed vomiting and diarrhea. So usually a few hours type of delay. Food intolerance, really specific examples provide an idea of what that is. And so I mentioned lactose intolerance. That's a really classic food intolerance. Some patients have heightened sensitivity to pharmacologic agents like caffeine, and there's individuals who have a food aversion, and that can be described as an intolerance as well. Next slide, please. This slide goes over what's happening when you have an IgE-mediated food allergy. So what your immune system does is it produces these antibodies, these IgE antibodies you can see on the left side, and they get bound once they're produced to effector cells, cells that carry out the responses. And a typical effector cell for allergic reactions of this nature are mast cells, and so those are the purple cells. And so upon subsequent exposure to the same food, so you can imagine that brown allergen as let's say a food allergen, then it attaches to those antibodies, and when it cross-links, meaning that it attaches to two of those antibodies, then that triggers the purple cell, the mast cell, to go into action, to degranulate, quote unquote. So it releases preformed contents out of the cell. And those contents are histamine, tryptase, leukotrienes, and those interact with your blood vessels, with your muscles, with the epithelium, which is the lining of your various respiratory tract, gastrointestinal tract, the lining of your organs inside. And once those mediators interact with those areas, then you get the symptoms such as rash, you get difficulty breathing, constriction of the airways, and you get the vomiting and diarrhea, which may occur in parcel with this. So this really nicely encapsulates what is happening when you encounter the food allergen again. Next slide, please. So when we're trying to decide in clinic whether a patient truly has a food allergy, because as we'll keep alluding to, it's not that easy quite often to accurately diagnose a food allergy. We really need to utilize as many of these tools as possible. The most important tool is actually the history, which unfortunately isn't used to its full capability and extent in certain scenarios. And so as allergists, we really want to focus on that, to take the time to get the details of what kind of exposure there was, how often there was that exposure in the past, have there been any accidents since, the amount of food, for example, that was eaten, the type of food, what foods that are priority allergens are tolerated by the patient, what are the other allergic conditions for that patient, details about the family history, and so there's a whole host of details that really help us decide. And then all these other items that are on this slide are really confirming what the history has provided as a suspicion. So the reason I like to spend some time talking about the importance of the history is it helps you in the audience when you're preparing for an allergist visit to come prepared with all those details and sit down and try to remember, even though sometimes waiting lists are long and the reaction was a while ago. If you just try to collectively as the family remember the details of what happened and jot them down on paper even, they can really make the assessment a lot smoother, because it's with those historical details that we can guide which skin test to do and which blood test to order, instead of ordering or doing too many tests. That's where you get into a lot of confusion, potential false positives, or even false negatives. And those scenarios make it even harder to decide when to offer an oral food challenge. We're not going to talk a lot about component resolved diagnostics or next generation tests in this talk. This test is mainly focused on the oral food challenge procedure itself. But there is research that's been ongoing to see if we can one day have a blood test that can replace the oral food challenge. That's still, we still haven't arrived at that moment in time yet, but I feel like we're getting closer through research. Next slide, please. So the oral food challenge really is the gold standard for diagnosis. We do it if there's been no recent convincing history in the clinical context. We like to consider it for delabeling, ruling out food allergy when other tests have been inconclusive, for follow-up of food allergy after a long period of avoidance, and for patients who've been told they're allergic when in fact they may not be. And if we're looking at blood test levels, for example, for when to offer it, it's best offered when there's about a 50% chance of tolerating. So for example, quite commonly, we're looking for a level of around 2 kilonewtons per liter for specific IgE tests. And it's only, I have to add, worth pursuing if the patient is committed to incorporating the food into their diet regularly. And we say that because there's been increasing research showing that many patients who pass their food challenge end up not, maybe because they don't like eating it and other reasons, not eating it regularly. And then it makes it not really worthwhile to do the challenge because the food allergy can return. So it makes it less worthwhile. Next slide, please. Now there's additional quote unquote newer rationales for doing oral challenges in the context of what we're learning more and more over the past decade about prevention and treatment of food allergy. So in the realm of prevention, some families are quite hesitant to introduce a food to a young infant at home for the first time. And allergists need to be able to offer oral challenges in that scenario when there's been no history of ingestion, but confusing positive skin tests or specific IgE tests. For treatment, allergists need to be able to offer oral challenges before initiating oral immunotherapy in certain patients whose diagnosis is uncertain. So we need to confirm it before starting the treatment. And then during the course of oral immunotherapy, oral challenges are very important to assess effectiveness because, again, we still don't have a blood test that can say that the patient has been fully desensitized or that the oral immunotherapy has done its job and will protect against accidental exposures. So, after the maintenance phase, we really want to do an oral challenge. Next slide, please. So before the oral challenge, there needs to be a discussion with the patient of benefits, risks, potential outcomes that the allergist discusses. There is a signed consent form typically. There are reasons for canceling or postponing the challenge, common examples being illness on the day of the challenge, uncontrolled asthma on the day of the challenge. And another consideration is knowing what to bring to the challenge appointment, bring foods, that are to be challenged in appropriate forms, stopping antihistamines several days beforehand, and also, really maybe bring something to be occupied because it's a several-hour procedure. So toys, games, things to read, and so on and so forth. Next slide, please. The challenge is done by a trained, experienced, certified allergist. And who is experienced in the management of anaphylaxis. Those are really, important criteria. It should be performed in an appropriate setting. How long does it take? Typically 3 hours if there's no reaction. And if there's a reaction, it can take in the range of 4 to 8 hours. These are approximates. The total dose of food is cumulatively roughly 4 to 8 grams of protein. So 4 grams of peanut protein, for example, would be about 1¼ tablespoons of peanut butter. We typically split into 5 repeated amounts and administer those amounts every 15 to 25 minutes. And there's some variability in how many amounts and the time interval based on how high risk the patient is and which food that we're challenging. Some of the special situations are what we should do when there are subjective symptoms, when the patient's reporting, for example, itchy throat, and we don't see anything. Should we stop or proceed? Again, the asthma control is very important. That impacts food allergy management in multiple ways, in addition to deciding if a food challenge should proceed. Food aversion situations. There are some children who are quite afraid of eating a food they've been told to avoid for a long time. So, what's the art of getting them to eat the food on the day of? And of course, infant oral challenges. Infants can't tell us how they're feeling. So, it really requires quite unique training expertise to do those. Next slide, please. On the day of the oral challenge, there's a reassessment by the team. The oral challenge starts with a small amount of the food again, and it's increased in intervals, with the goal being an age-appropriate serving. So that 4 to 8 grams is a rough range, but we want to make the amount age-dependent. The team, whether it's the allergist or a nurse or someone else on the team, is helping to constantly monitor along with the parents and the patient for signs of an allergic reaction, and the challenge stops if a reaction occurs and there's an examination and assessment of whether or not there should be further doses given. Next slide, please. So here we have a table with some sample doses for cow's milk, a 5-dose graded challenge, and where we're looking for a cumulative amount of 4,000 or so milligrams of protein. And that'll work out to a grand total of about 120 mLs, which is a typical serving of cow's milk. So that gives you a rough idea of the amounts that we start with. And as you can see, that last amount is much, much larger. So 83 ml, much larger than the first amount of 0.8 ml. And so we have the ability to stop the challenge after the first amount of 0.8 ml if there's a convincing objective reaction, for example. Next slide, please. And we're showing very similar type of protocol for peanut butter, with the goal total of being 4,000 milligram protein, which equates to about 4 teaspoons of peanut butter. And as you can see, again, the first amount is very, very small, 0.2 grams or 0.04 teaspoon. compared to the last amount of 3 teaspoons. Next slide, please. And so with the oral challenge, there's the aim to have a very conclusive diagnosis at the end, either green or red. Pass the oral challenge, considered to be no longer or not allergic, or red, did not pass the oral challenge. And the typical advice after passing is it's very important to eat the food regularly, adopting the diet, because if you don't, the food allergy could return. Each allergist and physician may have slightly different advice for how long to carry the epinephrine auto-injector for. Typically for my patients, I recommend still having it around until it expires, and then once it expires, no need to get a new one. For those who do not pass the challenge, avoid the allergen, have an anaphylaxis emergency plan, and carry the epinephrine auto-injector. And of course, there could be a discussion of whether something like oral immunotherapy is indicated. So at this moment in time, I'd like to turn it back to Jennifer.
Great. Thank you, Dr. Chan, and I'd invite you to turn your camera on, because we're gonna take a few questions, and from some of the ones that were pre-submitted and ones that are being submitted online. Before we dig into kind of this whole concept of pass, not pass, is it really worth it? Okay, so let's start with one of the first questions that was asked. It was around whether oral food challenges can actually be done with someone who has multiple food allergies.
Yeah, so that is something that really happens very often in my clinic. We are a tertiary care center, and we see many, many children who have multiple food allergies. And while there is data to suggest that children and patients with multiple food allergy have a lower likelihood of outgrowing, at the same time, that's not an absolute, and you can have different foods with different rates of outgrowing. So for example, if you have a patient allergic to milk, egg, peanut, and tree nuts, we do know that it's easier to outgrow milk and egg allergy than it is peanut and tree nuts. So typically for that type of patient, we're looking for the earliest opportunity to do an oral challenge for milk or egg. In terms of severity, because there is this possibility that patients can have severe reactions, more so than other patients, to certain foods, and that can apply to patients who have multiple food allergies. It doesn't mean, however, that if a patient has had severe reactions in the past, that we still can't consider oral food challenges going forward, because what we're doing is we're reassessing at specific intervals what's happened, for example, during accidental exposures, because maybe the severity is changing over time. And we're also looking at the chance of outgrowing, which is what I was talking about, like certain foods like milk and egg are easier to outgrow. So even if a child has had a relatively severe reaction to egg, let's say when they were an infant or a toddler, again, it doesn't mean that when they're school age or even older preschool age, it doesn't mean that they can't outgrow that egg allergy, and we won't be offering a food challenge.
Okay, so on this, the possibility for reactions, you talked it was a great review of what actually happens during the day, but when's the decision when it's like, okay, I think we need to now stop the oral food challenge? Can you walk us through that sort of scenario and how that works?
Yeah, so I was alluding a little bit to how what's challenging are these subjective symptoms that sometimes patients report during the food challenges. And so from the allergist perspective, it would be ideal if we consider proceeding with the challenge when there's a subjective symptom. But from the patient perspective, sometimes they feel it's too uncomfortable to proceed. And so the best way, in today's terms, to sort out that sort of difference in how to proceed would be what we call shared decision making. So, it's like collaborative care, shared decision making, but it's where really the physician talks to the patient and really describes what would happen if we were to proceed and how we can modify the original plan to proceed if it makes it easier or more comfortable for the patient too. So let's say when we look at that protocol that I showed earlier for the milk and the peanut, if the next dose of milk, so the first dose is 0.8 ml and then the next dose is 2.8 ml, instead of saying to the patient who's experienced some scratchy throat and is hesitant to go with the second dose, instead of saying, okay, the recipe says, the protocol says we have to go to 2.8 mLs next, what if we had a discussion with the patient and said, what if we repeated the 0.8 mLs? What if we modified and expanded the interval? So instead of doing this at 15 minutes, which was our original plan, we do it at 25 minutes, or we even extend it to 30 or 35 minutes.
Right.
And so that sometimes is quite helpful and then allows us to get the objective sign. So that's like
Right.
something like a hive or something that we can all see.
Right.
Patient, parents, and the allergist can all see.
Okay. Okay. That's helpful. So now, just for clarity, are the people that can do oral food challenges, are oral food challenges something that is done for oral allergy syndrome as well? Like we talked about multiple allergies, whether they could be candidates, but do you do oral food challenges for people that have got pollen food allergy syndrome or oral allergy syndrome? Or is it just for those that kind of those foods that or conditions that are likely to cause anaphylaxis?
Yeah, it's really for conditions that are likely to cause severe reactions. And so the two typical examples are anaphylactic IgE-mediated food allergy or food protein-induced enterocolitis (FPIES).
Okay.
With the pollen food syndrome, the oral allergy syndrome, no. I mean, there may be certain allergists who have the luxury of very little wait times who may be able to offer that, but your typical allergist, and we'll get into with the access, has a very long waiting list in Canada for oral food challenges, and therefore there's so many patients needing delabeling who have potentially anaphylactic food allergy that we just really can't, with our triage systems and the way we prioritize patients that we see, it's really hard to add a pollen food syndrome type of challenge to that waiting list when
Right.
there's so many higher potentially severe reaction type of challenges that are needed to be done.
Okay. Now, the other questions that have been coming in is around age. Is there an optimal age for an oral food challenge in your estimation?
There isn't actually, and so that's why I showed the slide with the sort of newer indications for challenge, that prevention scenario
Right.
where there's a family who has an infant, let's say a 6-month-old, and they know that early introduction, the topic of previous webinars, is very important, but there's hesitancy because maybe there's someone in the family who has an anaphylactic peanut allergy. And so that would be like a 5 or 6-month-old infant, and that just illustrates there's no age for which we need to wait for to do an oral challenge. So we should be able to offer oral challenges at essentially any age.
Right.
Even for an infant who's younger than that, like we may have an infant who is a couple months old and we're wondering about cow's milk protein allergy because of a reaction to formula upon introduction of formula, then we may need to offer for an infant who's just a few months old a challenge where they're having a bit of formula, maybe through the bottle in the clinic. So yeah, that's a really good question, but there's no
There's no
specific.
age. No, but are there situations where you go, yeah, this makes sense? Like, or what are the situations for an adult, for example, that you would say yeah, an oral food challenge is merited? Because we've talked
So
about, because when you're outgrowing, the possibility of outgrowing an allergy is one age category. But if you've been an adult who was diagnosed 20 years ago, are there circumstances where you go, no, this is something you should consider?
yeah, well, the thing about adults is typically they have reached a phase where they're very good at avoiding what they've been told to avoid. And so one of the things that really jumps out when we're seeing either adolescents or young adults or older adults is if they report that they were told they were allergic to something way in the past, and they've been carrying their epinephrine auto-injector and actually haven't needed it and have avoided for like 5+ years, like 5, 10+ years. And so that would make one really want to look at the skin and specific IgE blood tests with a very, very careful lens and be a bit more open to the possibility of offering the food challenge, even when the positive level is maybe slightly above the level at which one typically offers an oral challenge, simply because like that 5 to 10 years of no accidental exposures could supersede the skin test size at that moment or the specific IgE level.
Okay.
And there's certain patients who, you know, and we'll get into in the next part, sort of lower dose oral challenges,
Right.
but certain patients who could benefit from just finding out if like it's safe for them to eat foods with precautionary labels. And so doing a low dose challenge with like, you know, maybe 10 or 20 milligrams of the food protein of concern could really reduce anxiety and improve quality of life. And that would be something that an adult would be very, very eligible for.
Okay. Okay, now there were some specific questions. I've got two more, and then I think we should move on to the next section, just so we get an opportunity to cover that off, and we'll come back to more of these. But these were specific questions related to foods used in the oral food challenge. Is, you know, and is how to make nuts suitable for an oral food challenge. Because a lot of times, if you're you're going in for a tree nut, some form of a tree nut oral food challenge, they all say may contain peanut. And,
Yes.
you know, so that was one question. And then if you can also answer with the shellfish challenge, is it any kind of shellfish, or do you have to be specific?
Yeah, so the tree nuts are tricky because of all the labels saying may contain. And so what, practically speaking, we've done over the years in our clinic, because patients have reported difficulty finding a tree nut product that doesn't have that label, is we get them to purchase the actual whole tree nuts, not in the bulk food section, but at least in containers, even if it has that precautionary label. And then when they get to clinic, we wash, essentially, like we wash the tree nut. So we might use the hot water to wash them off, and then we'll dry them. And then if it's a younger child, we'll crush them up and weigh the appropriate amount. So that's one way to get around those labels. If you can find a product that says, like, you know, free of other nuts, then that would be even better. For shellfish, well, not necessarily any type of shellfish. So there's two main, as many know, two main categories of shellfish. There's crustaceans and there's mollusks. Typically, what we're challenging is crustaceans. That's like the more common shellfish to query. And within that group, it's most commonly shrimp that is being challenged, because that's the most common crustacean that's consumed. And if the history has mainly been with shrimp and the patient passes the shrimp challenge, then we don't necessarily need to challenge to crab and lobster, because these crustaceans are so, what we call, cross-reactive. They're so similar from a protein point of view. So a patient passing a shrimp challenge, they could very conceivably then go home to have crab and lobster safely. So that's an example.
Okay, terrific. Now, one last question, then I'm gonna ask you to go back to the slides, but I thought this question was useful given what we're coming up with. Is, so what is actually the criteria for passing? Like, is a mild reaction a pass?
So, I mean, the best criteria is not reporting any symptoms. Now, it used to be that mild reactions were deemed not pass, and then the advice was to avoid until reassessment, which is like a long-term view. Things have really changed in the era of oral immunotherapy. So now, as we'll go into with a little bit of the data, we have patients who we describe as low dose tolerant, higher dose mildly reactive. And so that's exactly the type of patient you're describing, where typically towards the end of the challenge at the higher doses, they have just a couple of hives, let's say, or something really, really mild. It feels quite wrong, knowing what we know about oral immunotherapy, to say, oh, you strictly avoid after that such a mild reaction. So many allergists are now flipping patients like that to what we call home-based oral immunotherapy, telling them to eat a certain amount, and it doesn't have to be that huge amount that they just had at the end of the challenge. It can be typically, for example, 300 milligram of protein, which is like, you know, dose 3 in that recipe that we had showed earlier, and then just eat that every day to desensitize and prevent those types of mild reactions from occurring in the future. So it's quite exciting what we're able to offer now to those low dose tolerant, high dose mildly reactive.
Right. Okay, terrific. So let's dig into that next section around pass, not pass, is it worth the stress? And maybe you can share with us some of the outcomes that you've observed in Canada on this topic.
Sure. Okay, so I'm going to go, you know, relatively quickly through this section because it's fairly research/data heavy, and then we can get to some of the punchlines during the Q&A. But I wanted to at the same time present some homegrown Canadian data as well as some recent research data to just, for example, describe to you what are the risks of doing an oral challenge. So in our BC Children's Hospital Allergy Clinic, we've published, to my knowledge, the only Canadian data on how often our patients in the past had passed or not passed their food challenges, and what proportion had severe reactions needing epinephrine. And so in our biggest analysis on the left side, we described that 33% of the challenges were not passed, but that's really, you know, quite good depending on how you look at it, because that means that we have almost 70% that were passed. And then we have overall 15% of the patients that had anaphylaxis. So of the 33% that didn't pass, close to half had anaphylaxis and needed epinephrine. Now, what's really changed in our clinic over the years is, again, we've offered oral immunotherapy more and more. And interestingly, for the preschoolers, we've published data that after the maintenance phase, when we're seeing if the patient's been desensitized, the challenges are much safer. So only about 1.7% have anaphylaxis at that stage. So right now, we're in the midst of doing an analysis of our food challenges done more recently, because on the left side, those were done several years ago, and our hypothesis is that you know, unexpectedly, we're having fewer challenges that are experiencing anaphylaxis, needing epinephrine, or not passing. Next slide, please. Now, if we're looking at the stage where we're doing the baseline oral challenge before starting oral immunotherapy, then we have data that epinephrine was given to 18% of the patients in that situation. But interestingly, because these challenges are done with the expectation that the patient is likely going to react or possibly going to react, then it's interesting, allergists are following their own advice to administer epinephrine earlier at the first sign. And so even for mild to moderate reactions, epinephrine is being used in this data relatively often. And it's reassuring that when we looked at this data, there weren't cases of severe reactions for these baseline oral challenges. Again, probably because we're not wanting to push the dose so high. And we're thinking that, you know, most of these are going to have some type of reaction. Next slide, please. We have data as well that's useful in the oral challenge context, that those who are supervised administering epinephrine autoinjector during oral food challenge have increased in confidence with recognition of anaphylaxis, administration, knowledge, and skill of the use of the epinephrine autoinjector. And so in our clinic, we, at the moment of anaphylaxis routinely for many years have handed the auto-injector to the patient or the parent and asked them if they're comfortable with that learning experience in the heat of the moment. And we have data showing that education is retained long-term. Next slide, please. Now, one concept I'd like to mention is the concept of thresholds, and I've alluded to that in the previous Q&A, but here there's a slide showing where you don't have an allergic reaction if you have an amount of food that's less than that black line. In the middle, if you eat a food that's right at that threshold, then you'll trigger the reaction. And on the right side, if you eat more than the black line, then of course you will trigger the reaction, and possibly it'll be a more severe reaction. Next slide, please. Here we have what is the concept of ED, or eliciting dose. And what it's showing is for peanut, the amount of peanut that will trigger reaction for 1% of patients allergic to peanut, for 5%, 10%, and 50%. And you can see how tiny the amount of peanut is that will trigger reaction for 1% of patients who are most allergic, most highly allergic. And that 5% or that 10% level is something that in research is something we want to get as much understanding of as possible when it comes to implementation of low dose oral challenges, to look at those who have lower thresholds, or to look at what level of allergen should be acceptable in precautionary labeling type of foods. But really the concept here is that people react to different doses of the food. Next slide, please. And this, again, reinforces that, and it shows it for not just peanut, but for all of these foods, all these 14 foods that were studied in this study here. And in that black line shows the amount of food which will trigger reaction, 50% of those who are allergic to that food. And really this graph is trying to illustrate that there's very different 50% amounts of foods depending on the food. So you have, for example, mustard on the left side, where relatively small amounts can trigger the reaction, all the way to, on the right side, shrimp, where it takes really very, very large amounts. Like this graph is actually showing 50% of patients won't react to shrimp until they eat over 10,000 milligram of protein of shrimp. And we've actually harnessed this data in our clinic in the past year, and we've started, instead of doing oral immunotherapy to shrimp, we've started offering low dose oral challenges to shrimp, and the vast majority so far have tolerated. And again, we'll just flip them into home-based oral immunotherapy. Next slide, please. There has been a recent paper describing this scenario that Jennifer was asking me about, of low dose tolerant and high dose mildly reactive. So we call these patients in this paper, quote unquote, not highly allergic. And so this slide is meant to, again, just pictorially show that 50% of patients won't react until they eat this much of these foods. And when you see it in a slide, a photo like this, it really gives you a sense that, hey, there's some patients where it takes quite a bit of the food to trigger the reaction, like one and a bit of a cracker if you're allergic to wheat, or like, over half of a peanut here if you're allergic to peanut, sort of thing. And so hopefully patients can find that reassuring that they could be in this subset where it takes more than these amounts to trigger the food. And it's just a matter of seeing if you're in the lower dose, lower threshold, or the higher threshold subgroups. Next slide, please. In that same paper, what doing these low dose challenges or these threshold challenges permits is at least discussion of other options. So of course there's the age-old advice of strict avoidance, but if you have a higher threshold, maybe you can regularly eat foods labeled may contain. Maybe you can eat certain forms of the food. Here it's saying sesame seeds, but not tahini, for example. Maybe hazelnut spread, but not whole hazelnuts. Or again, maybe we can arrive at a maintenance dose to do home-based oral immunotherapy for these types of not highly allergic patients. So just do 10 mLs of cow's milk every day if we've done that physician-supervised oral challenge. Next slide, please. So then really to summarize the benefits, risks, and outcomes, the oral challenge can help us decide if you're allergic or not, understand your threshold, which is a newer concept. It is essential for prevention and treatments such as oral immunotherapy. The reaction itself can be a learning opportunity. Again, you know, patients who haven't had an accident for 5 to 10 years are often just searching for hints as to what would happen if they accidentally ate. And that's where the even low dose oral challenge can help demystify. And of course, quality of life may be improved. And so that is contrasted with the risks being allergic reactions, really, that's the risk, including anaphylaxis that can happen. In our clinic, we have that data. I would say that's probably the highest rate of anaphylaxis published in the literature. And you know, since then, even in our clinic, I have a feeling that our challenges have lower risk of anaphylaxis and severe reaction. And in terms of outcomes, basically passing or not passing, really in the lead up to this, we had some discussion about whether we should call this not pass or fail. And we feel that the word fail really, you know, just is too judgmental and provides the wrong connotation. So we're not in favor of that descriptor. So really, we like pass or not pass. So I'll just hand it back to Jennifer.
Okay, great. Okay, we're going to take a few more questions. This super interesting, the concept of thresholds, and naturally there's some questions about that concept because now we're, you know, if we've moved from this world of strict avoidance to, well, maybe not, people are interested in better understanding the threshold concept. So, you know, the idea that you shared with us that people can be allergic to different amounts of an allergen, but does that stay constant? I mean, you do hear people say the allergen on added exposure can become more severe. So does the threshold stay constant? And if it doesn't, what impacts it? What would change it?
Yeah, so I mean, in my world, being a pediatric allergist, really age is what can change the threshold. And so you can have an infant where there's a relatively mild reaction, and there's data showing that infants generally have less anaphylaxis and milder anaphylaxis when it occurs. And then as the child gets older through the toddler years, the older toddler years and the younger preschool age years and the adolescent years, the threshold can change, the severity can change through those years. So it's not necessarily constant, but at the same time, we do see patients who we say are in a more severe phenotype. And the specialty is still trying to grasp at what can predict future reactions being severe or not. And we don't have that test right now that can accurately predict what future severity will be, other than knowing from describing larger groups of patients that they can remain in the more severe phenotype long term. But because it's not an absolute, that's where this whole concept of, you know, for the patients who are keen to explore it, doing an ED5 or an ED10, like, or, you know, whatever lower threshold the patient is comfortable with, can be helpful to figure out what the current threshold is.
Okay, now, but what about the role of things like cofactors? Like, does that shift, you know, like if someone is exercising or if they're not well, does that change their threshold level?
It definitely does. So, you know, there's a lot of research now describing, and a lot of that is actually now gathered through the oral immunotherapy experience. So when patients are undergoing oral immunotherapy, we regularly caution them to not exercise, for example, for 2 hours after their dose, if it's a severe illness that they have, to hold their dose, to not updose during illnesses, to take on a with food, so it's not an empty stomach.
Right.
Really, cofactors can include other medications as well. So, we've learned a lot about how severity is impacted by those types of cofactors. And so an oral food challenge appointment, is free of those cofactors generally, because I just described that we'll potentially even cancel the challenge if there's one of those cofactors. And so we also don't want to give the impression that, if a patient is unwell, when they eat that same amount of food, the same thing that will happen as what happened on the day of the challenge.
Now, will a patient who has asthma as a comorbidity, does it change your perspective on an oral food challenge?
Yes, in the sense that we want to ensure that the patient's asthma is controlled on the day of the food challenge. And so if they're, having an illness, let's say, and their asthma is flaring up, then no, it's not safe to proceed with the oral challenge because of their risk of anaphylaxis. It could make the anaphylaxis more severe if the asthma is uncontrolled. So it's a big red flag,
Right.
having uncontrolled asthma and ingesting the food intentionally.
Right. Yeah, I guess a real key message for our audience, if you are managing asthma, it's so important to have that asthma in control, even if you have accidental exposures. That's a big key message, I think, to the audience.
That's right. Yeah, like it's a whole other webinar or session
Yeah.
about the interaction
Yeah.
between food allergy and asthma. And
Yeah.
it's a tricky one, which is why it requires so much discussion, because
Right.
you can have asthma at so many levels of severity
Right.
and levels of control.
Yeah.
Uh,
Now,
yeah,
we did a session earlier this year with Dr. Mack on that. So if people are interested in learning more, they should go on to our recorded webinars and take a look for that. So a couple more questions, because then, and we are going to go over time. I just want to let the audience know that, because we do want to get to the access picture, but I just have a couple more questions on this before we go back to those slides. And because this question came in from a few people, was around kind of managing fear and anxiety around oral food challenges, and managing that, there might be, the parent might feel differently about the oral food challenge than the child. So like, can you speak to what you do to help people manage fear and anxiety? I mean, that's what we're all afraid of, is we don't want to react.
yeah.
So
It's
what's
actually,
your approach?
I'm really glad you're asking this, because it's so fundamental to the whole procedure of, being able to recognize this and to acknowledge it, and not to brush it off. And so that's, I'd say, the first thing, that it's very, very real. The food aversion that I had mentioned earlier often stems from patients and families being told that this is a very dangerous, allergy to have. It can be potentially life-threatening. And when those messages are repeated and recurrent, then the child, can develop this aversion where, all of a sudden it's like they feel like, why is the allergist flipping a switch? They just told me for so many years that it's dangerous, and now they're actually wanting me to eat. And so it's very easy to put yourself in the child's shoes or the patient's shoes and understand that, because they think it's easier just to go on living avoiding, especially the ones who have successfully avoided the allergen for many years without accidental exposures. That's where it can be most difficult to get buy-in. So of course, we can go through all the benefits that we went over during this talk, but often that still may not resonate with the patient, because they feel that it's just easier to go on living like this. Our research team, is really very preoccupied right now with this topic, and so we've developed a food allergy anxiety screening tool that's been validated for looking for parent food allergy anxiety. And I'd like to thank Food Allergy Canada members for assisting with validation of this tool, which has now been published. But this tool is allowing us to now work on research to look at what a high score for food allergy anxiety is versus a medium versus an acceptable score. And it's with tools like that that we can better tailor the limited finite resources we have to reduce or alleviate anxiety to those families. And so it's really, this is very timely, because we're just working on this scoring system right now as we speak. And hopefully that'll help us decide. So we may have, let's say, 10 or 20% who really need some type of intervention, whether that's counseling, whether that's going to, like, in BC, we have this Anxiety BC type of organization, or actually seeing a registered psychologist for formal psychology care and reduction of anxiety before doing, because it could really be not the best solution to just ram through with an oral challenge before that patient is ready. And it can result in, quote unquote, trauma, and result in taking a step backwards and not being able to offer more oral challenges in the future if there's been a bad experience.
Got it. Okay, that is super helpful. Okay, I want to move to the last section to touch on access.
Okay, thank you. So yeah, I want to make this section the most brief, but really also wanted to pay attention to and give you a sense of how few allergists there are relative to how many patients have potential food allergy and how many non-allergist physicians there are relative to allergists. And so as you can see from this slide prepared during our National Plan of Action, that there's not that many allergists. They're really quite focused in Ontario and Quebec, and even relative to the population in those provinces, we're still looking at like 0.6, for example, allergists per 100,000 in Ontario, and that's well below what is ideal. Next slide, please. And so our research group actually published a couple of years ago the only oral food challenge implementation study that we're aware of, which employed mixed methods, so both focus groups and surveys. And before we get into what the allergists identified as barriers and solutions, I just want to describe that we found that the allergists that responded to the survey were predominantly younger, so they had been in practice on average 10 years. 66% had received moderate extensive training, meaning that almost 40% had received very little training during their fellowship, and that those allergists that responded were doing about 12 challenges a month, which is 3 a week, which is not many. So even though most that responded were doing challenges, they weren't doing that many. And the BC allergists, where we looked at the ages that they challenged, it was 50% that challenged infants, and so 50% didn't offer infant challenges. Now, when we asked them about barriers and solutions, you can see that allergists really are, quite uncomfortable with the lack of support staff, the lack of time that they have relative to the time they need to allocate for other tasks in their clinic, the lack of office space, because these patients, as I described, are in the office for so many hours. And so, those are very influential in them deciding how many challenges to offer and whether to offer certain challenges. And then solutions they proposed were criteria for which challenges should be done in the hospital versus the community. I think we can all agree that it would be helpful to have more guidance on that. Patients agreeing to consume the challenge, consume the food regularly after a negative challenge, after passing the food, and then specific fee codes, because there aren't oral challenge specific fee codes in every province, and that actually turns out to be quite a barrier. Next slide, please. In terms of the patients or the parents in this case, fear and worry were big barriers. So worry about severe reactions needing epinephrine, worry about the child's anxiety, which we just finished talking about, child specifically being afraid of reaction. So that's why it was so good that we just dealt with that question. And then worry about management despite the food allergy and not knowing enough about benefits and risks. So there's really, quite a few fears and worries, and those actually are higher in parents who have not done an oral challenge. So I really find it quite interesting with our audience poll initially that although over 50% describe familiarity with oral food challenge, well below 50% have actually undergone an oral challenge, and we can discuss that a little bit more later if it comes up again. Next slide, please. So in terms of what we can do to increase access, so Jennifer may be elaborating on this, but we've talked about it in previous sessions about the National Food Allergy Action Plan, which is a collaborative effort between Food Allergy Canada and the Professional Allergy Organization in Canada, the CSACI. And so when we're speaking to the federal government in this action plan, we're trying to brainstorm how to increase access, because we want to convey to the government that Canadian families are really struggling to get timely access. And there are very, very real barriers, and we need to continually evaluate and elevate food allergy as a serious medical condition and increase access as a priority for the government. And once they've identified it as a higher priority, then hopefully the funding can follow to increase access. Next slide, please. So to summarize the entire webinar, really what we've hopefully achieved is looked at consideration of an oral food challenge being something that needs to involve shared decision making at every stage, including during the oral challenge, to convey that challenges must require supervision by an allergist and should not be done at home independently. That oral food challenge, while they involve the possibility of reactions, passing one leads to new dietary options, and not passing one provides information for guiding food allergy management. And the risk of anaphylaxis is there, but it's not overly high, it's not unacceptably high. And with time, as we learn more about treatment and prevention of food allergy, the risks of oral challenge, as well as have more newer age investigations that can eventually replace oral food challenges, this procedure will just hopefully get better and safer over time. Also, with respect to access, that access varies according to location. So you could see how different provinces had different numbers of allergists and allergists per 100,000 population. So access will vary according to where you live in the country. And even within specific cities and areas, different allergists may offer different types of oral challenges. So I said that, certain allergists don't offer infant ones and other ones do, and things like that. So that's something that can be confusing and will need time for families to get a handle on.
Great. Okay, well, thank you so much, Dr. Chan. There are a couple of questions, and then we'll close off the session, but some things did come up around access, okay, not surprisingly. And we've heard this from our community. It's like, how do I access an oral food challenge? Do you envision a time where the oral food challenge becomes a standard requirement in an allergist's practice?
Yeah, that would be ideal. So it's something that, those of us who, spend a lot of time on food allergy doing research or clinical care have been advocating for, I feel like, for decades. The oral food challenge procedure was first developed many, many decades ago, like in the 1980s or so. But, it's been, it feels like over 40 years, and the access is still, as we've just finished describing, still not as we would like. So although I acknowledge that would be ideal, I am also a pragmatist and realistic that I don't think we're going to have 100% adoption and have it as a standard requirement. There will be too much pushback. Those barriers that we identified in our study, they're tough barriers to crack. And allergy, although in our world is the most important, when we look at healthcare in general, this is something that still needs a lot of attention in increasing its priority. So to have it as a standard requirement would need all levels of government to really acknowledge how important food allergy is, right, and have the proper funding to get around all those barriers that right, the allergists had identified.
Would you envision it being possible with a single dose, that kind of low dose challenge? I mean, conceivably that has fewer barriers in terms of time commitment to that. Is that, what's your thought on that from a practice in Canada?
Yeah, that I do feel is more realistic. And so, although it's controversial, that paper that we had referenced in our talk on the not highly allergic patient group, to discover that group would require doing more low dose oral challenges. And because those are safer, then really, if we can educate more about carefully selecting the type of patient who would be comfortable with that, then yes, I do feel that it's lower hanging fruit, and it's something that we can, also parcel with the precautionary labeling
Right.
issue, which I know that Food Allergy Canada is immersed in and advocating for when at the international stage. So if we can somehow connect those two concepts,
Mm-hmm.
all of the learnings that you're applying from all the international work on precautionary labels, if we can say, okay, now we've established in Canada that a typical may contain product has this many milligrams of peanut protein, let's say in the case of peanut, then it would allow allergists to, discuss that type of threshold with patients and say, hey, that's actually not that much of the food. And so maybe both you and I, now that we have that information, can feel more comfortable doing a low dose oral challenge in the clinic. And so I know that that's what I've struggled with even in my clinic, the lack of Canadian specific precautionary labeling, allergen data. I when I've offered these low dose challenges, I'm relying on American data, on some of your UK data, on how much milk is in a typical cookie and things like
Right.
that. It's just,
Right.
it doesn't give me the confidence
Mm-hmm.
necessarily that I need to say that, okay, now we've done this challenge, you can go out and buy a Canadian cookie with a may contain label.
Right. Okay. One last very quick question, because it came up through the chat, and we had more questions than we were able to answer, but because you were talking about the anxiety tool, is that going to be rolled out to allergist practices, or how might the listening audience be able to kind of access an assessment using your food allergy anxiety tool?
Yeah, I mean it's very new, but it's been successfully validated and published, so we're very happy about it. In terms of increasing awareness, you can start using it with your allergist, and sort of anyone can use it, and maybe to disseminate it, because like Food Allergy Canada, you were so helpful in getting your members to help validate it. Maybe there could be a communication
Okay.
about the paper at least,
Right.
or the tool, and we could work on how best to disseminate it to your members, because I do
Okay.
feel that's quite important. And then it'll be even more important when we have the scoring tool that we're just working on
Right.
with Dr. Proteger's group in Winnipeg. And we're just in the process of submitting an abstract to the American Academy meeting next year on the scoring tool. So I would welcome us to continue to collaborate on that, and to disseminate not only the tool, but what will be a high or an acceptable score, because I think that's equally important, not just having a tool, but knowing what a high score is.
Got it. Right. Terrific. Okay. Well, listen, I'm going to thank you very much for your expertise today. We really appreciate it. And thanks to our audience for listening in. We can turn off our cameras at this point.
Thank you very much for, again, inviting me to speak, and for everyone's attention. It's just been a pleasure. And thank you to Food Allergy Canada for the collaboration. Always really enjoyable.
Okay, thank you very much, Dr. Chan. I would like to just give you a couple of things about what's coming. There is going to be a survey for those of you who have attended our webinars before. through GoToWebinar, you're going to get a pop-up screen, and we'd really like you to complete that survey. It will also come in via email in the next hour. There are some questions in that about access to oral food challenge, so we want to make sure we get your feedback. It informs the activities we do and the educational sessions that we put forward. We also have a host of back to school resources on the site, so be sure to check them out at foodallergycanada.ca/back to school. There you're going to find videos, handouts, hacks, and more. And new this year is a checklist for parents and students getting ready to go back to school. Lastly, we'd like to thank our sponsors. You know that Food Allergy Canada is a not-for-profit charity, and we completely are reliant on donations for support of the work that we do. You can consider a donation to our organization. We would greatly appreciate it. And you can visit foodallergycanada.ca/donate to learn more about the impact of the donations. And lastly, thanks to our sponsors under our Back to School campaign, Peanut Bureau of Canada, Chapman's Ice Cream, and Emerade. Thank you for your participation in today's webinar. You can view a recording of this webinar at foodallergycanada.ca shortly. Please also share it with others who may benefit from this content. Thank you.